Okay, we're going to get started with the governing board meeting of the Department of Health Facilities and the Los Feliz Community Program. Go around the table so we can establish our quorum. I'm Gabrielle Sanchez Sandoval, Deputy Secretary for the Department of Health.
Bill Shelter, Chief of the Department of Health.
Angela Solis, Assistant Secretary. Jill Marshall, Administrator of the Feliz Community Program. Carmela Sandoval, Administrator of Sequoia Adolescent Treatment Center.
Shauna Hartley, Administrator of Turquoise Lodge Hospital.
Susie Archuleta, Long-Term Care Administrator at NMDOH.
Michelle Fields, Medical Staff Office.
Mitchell Lawrence, Department of Veteran Services.
Todd Winder, Administrator of Fort Bragg Medical Center.
Melinda Wolinski, Assistant General Counsel.
Charles Aramillo, Deputy ASD Director.
Roberta Vino, Facilities Office.
Roy McDonald, ASD Director.
Mary Beth Ansler, DOH.
Jeff Esquivel.
If you have anyone on the phone, if you could please identify yourselves.
Hello, Gabby. This is Jose here at the New Mexico Rehab Center.
Thank you, Jose.
Good morning.
Go ahead.
Good morning. It's Kiki Knowles from 18 and Long-Term Services Department.
Is there anyone else on the phone at this time? Okay, Jose is joining us by phone today because the Joint Commission is at the New Mexico Rehabilitation Center, so he will not be here in person today. And Francis Tweed from the New Mexico Behavioral Health Institute is under the weather, so Susie will be giving her presentation. Is that correct? Thank you. We may have Dr. Collins from NMDOH join us later on the phone to present the policies and credentials. Has everyone had an opportunity to review the agenda, and if so, can I have a motion to approve the agenda as written?
Motion for the agenda is written. Second.
I second.
All in favor?
Aye.
Anyone opposed or any comments about the agenda? Seeing none, it's passed. Approval of the minutes from the previous meetings. You should have gotten the October 19th minutes in your packet. If there's no changes or amendments, I can get a motion to approve the October 19th minutes.
I'll make a motion to approve the October 19th minutes.
Second. Carmela, thank you. All in favor?
Aye.
Anyone opposed to the approval of the October 17th minutes? Seeing none, they're approved. Vic was going to try and join us, so if she does join us on the phone, I'll give her an opportunity to speak. If not, I will move right into the governing body reports. This time we'll start with Todd Winder. Todd usually goes last. That's so unfair. That one's going to go first.
Okay.
So Todd.
Ready? This is the Fort Bragg Medical Center Governing Board Meeting Administrative Report for the second quarter of fiscal year 2018. First of all, we have the presentation of our services we provide. We have 200 duly certified beds. Our E unit is for skilled rehab and extended care. It comprises 70 beds, 10 of those dedicated to short-term rehab and the other 60 to high and low complexity long-term care patients. We also have our dementia care unit of 90 beds with a secure unit for 24 males and 24 females, and the other 42 are for high and low complexity. And our veterans unit, which is a 40-bed unit, currently all male, both high and low complexity. Our licensing and certification, recent surveys. Of course, we are visited by the Centers for Medicare and Medicaid once a year. Our last survey was in June. Our Veterans Administration survey was also in June. The State Fire Marshal visits annually, and our Department of Environment is also an annual survey. This next slide is our utilization for the quarter. In the second quarter, our days were up by about 150 days or more or less, for a total of 11,658 days. And we had 27 admissions and 22 discharges in that time period. Continuing on with utilization, our average daily census for the quarter was 126.7, which was a little bit higher than the first quarter. And our percent beds available that were occupied, we were at 84% compared to the previous quarter, which was 83%. In the area of finance, showing our revenues and expenses there. Our revenues were up in the second quarter, as well as our expenses. Most of that increase in our expenses in the second quarter was due to contract nursing. As you can see there, that really jumped up in this second quarter for us. Continuing with finance, indigent services, 707,000 indigent services in the second quarter, which is 17% of our revenue. It's running between 17 and 18%, as you can see there. In the first quarter, it was 17.8, and in the second quarter, 17.0. Our time to collect for the collection for the quarter was 67.8%. Year to date is 84.26. That dropped down considerably just with some issues we were having with ISD. And also I had a couple people off sick from the business office. One of our primary billers was off for 2 or 3 weeks, and then there's been some adjustments in people in different positions, but they are caught up again now, so that's right back up where it should be. January, I believe we've already collected like 130% or something like that. So it's corrected itself anyway this year. Human resources, our number of staff FTEs is 265. Our turnover for the quarter was 0.96, with year to date of 2.58. Direct care total FTEs, we have 34 with 21% vacancy. Indirect care of 16 FTEs, which is 11%, for a total vacancy of 50, which is 16%. We held a rapid hire in November, which got us down to that. Previous to that, we were running about 24-25% vacancy. So our rapid hire was successful, and so far the one we were able to hire is still stuck around, so we feel pretty good about that. Some of our clinical numbers. Our actual PPDs in nursing was 4.02, again with an 88% bed availability. Infection control, we had total infections of 31. 87% of those were HAI infections. We had 11 multi-resistant organisms during the quarter. We had quite a few of those. But again, those have been corrected. Off our new Abacus system that we use in the building, it kind of points out our top 5 care areas where you're at risk based on your surveys and your MDSs. This was an alarming one I saw. It's not as bad as it looks, where it says death is a high risk. I think we lost 2 people within 30 days of admission or something like that, and that's what made that look so high, but it's not that bad. Choices, that is one of our high areas. It's continued to be in the 2 quarters we've run this program. That's mostly due to residents reporting they don't have choices necessarily as to when they get up or go to bed, or when they take a bath, or what type of bath or shower they get to take, those kind of things. Bringing personal belongings, that sort of thing. Our moderate risk ones were participation in care planning, personal property, and activities. This program is interesting because if they answer no, they don't attend activities because they don't want to, we get deemed for it, so to speak. Just as a focus area, to see can we provide them something individually so that they're not without activities. So those are our 5 high-risk areas of that. It's a good program, and we're starting to use this type of data to direct our efforts there at Fort Berry. Our satisfaction surveys, also this comes from the Abacus program, both resident and family satisfaction. our residents. As you can see there in the 4 areas that it designates the questions to, quality of life is 91%, satisfaction, quality of care 84%, quality of service is 90%. And then the endorsement score, if I get this right, the endorsement score is the difference between the people who are very satisfied and the ones that aren't satisfied. The difference in the percentages. So as long as it's the higher the positive number, the better you're doing. The first quarter we took this, our resident satisfaction endorsement score, I believe, was like -5. And so in 1 quarter, we've been able to increase that to an 18, which is, we consider to be a good trend. Our family satisfaction, again, for the 3 areas and the endorsement score, and those stayed within 1 point of each other from the first quarter to this quarter, so we're maintaining there. These are some of our training initiatives. We continue to work on our Certified Nursing Assistant program. This past quarter, in fact, as we speak, they're finishing up this week. We brought in a mobile service to do our CNA training. That has gone really, really well. The training has been exceptional, so if anybody needs that, I can give you the lady's information. Like I said, we started out with a total of 22 students in the class. 12 of them were our students, and we've lost 1 from that training. It's very intense. I mean, she's a very intense instructor. They go through about a 2-week period, 2.5-week period, where normally CNAs get trained in 6-8 weeks. So it's been really good. We're also developing and working on our clinical competencies with our direct care nursing staff. That is a focus area, one of the big areas on the new conditions of participation. So we're working on those, and then we're reviewing the CFR training requirements as also part of the new conditions of participation. That's it. Is there any questions?
Is the CNA training expensive?
Well, we paid $850 per student. When we were training them ourselves, my estimate was it was costing us about $1,200 to $1,300. I think we're actually saving money. I think that way. And compared to what we would have, we thought about contracting with our local university to be able to provide the classes, and their charges at a minimum was going to be $1,500.
Is she more effective than we have been?
As far as training,
And when we get the cheaper product, is the end result the same? Costing us less.
it's costing us less.
Person.
I guess probably type 1 go back to the 12 school.
Right. Yeah, this is the first class.
Yeah, this is the first class.
This is the first.
This is probably something we want to monitor. Because
She's in pretty high demand, so she goes all over the state.
Any other questions for Todd? Todd, I want to let you all know that Lynn did join us on the phone. She doesn't have anything to report right now. So, Jose, are you on the line? You're next up to give your report. This could be interesting because.
This Thompson next.
Jose, are you on the line?
Yes, I'm here, sorry.
That's okay.
How's everybody?
Good.
Good. Well, look, we got 3 surveyors here at our facility joint commission. They showed up yesterday. We've got Ricky Yates, which is one of the engineers. We have James Ferrer, which is a nurse practitioner certified in psychiatry as well as NMDOH talk. And 4 other nursing. We got Jacqueline DuPlantis. Both are very helpful. Both are very informative. Great to learn from. Our team has been communicating with them back and forth. They've been stepping up. They've been really helpful as well. We've got through the first day. We're going through the second day right now. Here in a few minutes, Gabby, here about 10:30, they're going to be going through the quality infection control, which I might have to cut out, but I'll log back in as soon as that piece is over. But I'll get started.
Now, why don't you just give us an abbreviated review, Melissa, some of the highlights, because we have the paper copy anyways.
Sure, for the Joint Commission.
No, I mean of your report in general.
Okay, yes, yeah, okay, let me go through it right quick. Just some of the highlight points on page 3. I just wanted to point this out for inpatient social rehab. We are already meeting and discussing the opening of our inpatient, which will be, we set the date of March the 5th. And this will offer again another tier, lower level tier from detox to inpatient down to IOP. This will close the gap in that for detox patients, for substance abuse patients. So we're all excited. We've been working on that. We're going to be moving forward with that opening. We've got our counselors, we've got staff. Now that we've got another position, which I'll go into detail later about, that's going to be something to look forward to here in March. Page 4, we touch on MRU. Our admissions, this quarter we've had 30, so total patient days are about 543. One thing about our medical rehab unit is there's some stringent Medicare guidelines and rules that we have to abide by in order to receive payment back, in which we have to enter data into this uniform data system on treatment options, so that way we can receive payment, or we comply with those Medicare standards, so we don't lose our Medicare licensure. At this point, we're 100% in our appropriateness in our admissions to MRU, which is really great. We have lost 42 referrals in this the last quarter, and again, this isn't but there's not bed availability. This is due to the fact that they just didn't meet those stringent care guides. We need at least 2 therapies, 2 qualifying therapies, such as PT, OT, speech. Within those 3 areas, we need them to qualify so that we can provide that individualized, intensive one-on-one care. Some were due to non-SNP units that discharged to home health. Some we never heard back from the referring hospitals. And we're following up with some local hospitals as well on what we can do to help further streamline our acceptance time into MRU. In the uniform data system that we use, nursing facilities use the MDS, we use the UDS system. So far, we've serviced 52% of those are Medicare, 44% are our Medicaid or unfunded, which is higher than our comparisons to our other 922 rehab hospitals. We exceed that regionally and nationally. 4% are commercial payers. Our length of stay there is averaging about 14.7 days. Something to brag about is our discharge functional improvement measures this quarter. We're at 98.8%, which we're just 1%, one small 0.1 away from getting that 90th percentile of higher performing rehab centers, which is a great milestone for us. When we compare that to our quality assessment, our report card that's in with our management plan, to look at the satisfaction scores where they're individualized, they're focused to nurses, doctors, and staff. Communication with the nurses, 93.7%. Communication with doctors, we're at 90.5%. The responsiveness of our staff, 92%, which is excellent. That definitely shows it provides that great improvement in patient satisfaction. Our primary goal is to discharge those patients back to the community or back home. 81% of those patients have been discharged safely back to the home of the community. 11.6 long-term care facilities. That's due to us accepting patients who don't always present as they were referred, and we treat them and make sure that they get transferred and get the care that's the most appropriate for them. 7.1 have been transferred to an acute center. The number of therapy hours, again, our MRUs system is based off of these three therapies, OT, PT, and speech. The most hours there, as you can see, all those patients, the 524, 523 hours have gone into those therapies like that. Referral sources, we still continue to work with UNM, UMC, and LUBA, our two local hospitals, Cabinet So all these hospitals within our region we're communicating with. We share different systems where we can share our bed availability. They send us links to their documentation so we can grab that and make a faster decision as well for it. Went on to page 5. In our CDU unit for our detox, we've got those 8 beds. Our quarterly census this quarter's been 45. We're averaging about 6 days in the detox. Some of the measures we've been compiling this past quarter is monitoring the patients, how well they're doing, following up with their aftercare appointments. 78% are compliant, which is great. Only 1% of those patients ended up with AMA. This is really great news. Those that remain sober 7 days after they discharge from our facility, 80% of those stayed clean. So we have transferred them over to a lower level, such as inpatient, 50%. As we open up our inpatient in March, of course, those 50%, we can definitely start tearing those down or start with those patients, including them in our inpatient program. So that will probably lower as we're not transferring now to that lower level of care. Higher level of care, 3%. IOP, our services there, we're at 33 patients. We had 5 graduates this quarter. We average it down to the quarterly daily census for the patients we serve, which has been 10. We have a large number of unit hours at 683. So far in this outpatient, we've serviced 290 patients in combined quarters. We wanted to look at satisfaction scores, and we wanted to find out on a report card, individual and give us the responsibility to staff, community resources. Well, the responsive staff, 96%, services they provided 96%, the connection with community resources on discharge of 97%, the content of the materials in the program at about 96%. So definitely some improvement there with our IOP and DTOP. Page 6. So as you know, same as last quarter, we are working on our front-end collections as well as our back-end collection. This quarter was in terms of revenue collected. And we're making great strides in prior ops, eligibility, utilization reviews, just changing the way we do things around here, which is showing some positive improvement. The total revenue collected this quarter was about $800K, and collectible about $270. The next page over on page 7 shows, some of the progress, of course, the strides that we're making in comparison to the past fiscal year. Definitely we're exceeding, we're already, 6 months in, we're in comparison with FY7. In this fiscal year, we hope to meet our budgetary goals, our financial goals, especially with some of the initiatives we've got going forward with our programming. Page 8, our capital project is the same last quarter. We'll continue on our back swipe blocks or camera system. Talking with George Morgan, George is down here for our Joint Commission survey. In our life safety, they did let us know that there's a switch lock or a switch stop that needs to be put into our facility, which might go on capital, which I'll probably include later, as well as some of the demolition of our old warehouse, which we're going to meet with Mr. Flinner and George Morgan on Monday. So next quarter, there'll probably be more capital projects on this sheet. page 9, the Joint Commission this year. They've, we're so far so good. I'm happy to report our life safety survey has gone really well. For the emergency stops, simple fix, a lot of small little fixes, little things that we were able to get out of the way yesterday as well as today. It's gone really well. Our medical rehab unit was surveyed as well. We got the report, only 4 findings, really small findings. They're monitoring our detox, or surveying our detox area. They did survey our IOP program yesterday, and really well. The counselors and staff of the program all went excellent. Again, there's the types of small deficiencies that they noted were within the moderate to, but mainly all the low categories on the way they tier items. So definitely quick fixes and more just educational opportunities. Hopefully we'll have more of a detailed report by the end of today. They're free. Going down to page 10. Our human resources, what our focus has been my focus has been in the last 6 months, the staff, making sure we get those individuals in the right places, increasing our turnover rate as well as our vacancy rate facility so that way we balance out the services that we offer. So you can see we continue to make progression each month in our vacancy rate as well as our turnover rate. We've hired 16 this quarter, have 19 vacancies. I'm happy to announce we did recruit, and we are hiring a new position to our facility. Her name's Dr. Marilyn Hines. She'll be going through credentialing this afternoon. In her facility, she comes from Artesia. We're happy to have her. She's specialized in geriatrics, hospital, skilled nursing facility, family practice, geriatric board certified. We're happy to have her on board. She's excited to get started. Her first day of employment will be on the 29th of this month. So that's going to be a great addition to our facility in terms of where we're going the next 6 months for our programs, especially as we strategically enhance our census as well as our programs. Our marketing outreach, page 11. Local hospitals, we continuously have meetings with Eastern and Loveless. Eastern, MRU, medical rehab unit is a huge focus, as most of our efforts there are referral based. How quick can we get those referrals? Do they meet our criteria? How do they know? How can we get access to their systems? We're working together with the local hospitals so we can share reports, share checkoff lists or short forms where we can, for their therapists or their physicians, and mark what are the key elements or items they need to quickly qualify into our inpatient rehab because those EMS requirements. We're having continuous meetings on that. Hopefully this month we can have some closure and have and start measuring how fast it takes for those patients to be admitted into our facility. So we hope to streamline that and help build as we move forward. The New Mexico Rehab Foundation exists. We met with them at the top of this year. Some new members have been added to the foundation. Some have left. They want to continue working with us. They were held a meeting here with us to discuss what our plans are as well as what their plans and their plans are. Really positive, really great. So we're going to continue with them. They come from stakeholders within our community in real estate, banking, within the hospitals and providers as well. Our marketing to those DME companies is key as they share with our local surgeons information about us where they should receive the best care for some of those ortho patients. Frontier and Compass and J&J, they're our primary focuses in terms of going out in the community and meeting with those to share, okay, this is what we do best. This is our brand and service. They're really helpful. They come to visit us often. The Mayor Health Care Solutions Committee is something we're involved in every month. They do want to see our new position. They heard we were getting a new provider to our facility. Of course, the mayor asked to bring her, introduce her, come back and just to discuss about our facility, what's working, and how everything is going here. And nothing but positive efforts. Of course, we'll go to the 2 local hospitals, as well as providers from the community, a lot of stakeholders from the community in that. We're a continuous part of that. We're going to continue to build our local university. We're still in collaboration with them and their nursing program and their OT program. We'll be giving a presentation to their new grads coming up here in March. So maybe we can try to recruit some of those new basics nurses and hire them right as soon as they graduate from school. So we look forward to that in March. We still continue our collaborations with our POs and parole department. So this is a success to our IOP class. Page 12, we completed our 2017 QAPI evaluation and our management plan. Our quality assessment improvement report card has been completed. Just in brief, the report's in with the management plan. There's definitely some areas for improvement as we identified in 2017 back in June, July. Definitely some areas that we have actively been moving forward and progressing with and enhancing. I think as a result, the past 6 months will probably show within our Joint Commission survey, as our focus has been really to rebuild the quality of the program here at the New Mexico Rehab Center. Coming up in 2018, the scorecard in which which we put our measures and performance scores, we're looking to add a few things such as antibiotic stewardship, infection control items, pain management, safe opioid prescribing. Want to move to a higher reliability type organization, which promotes a culture of safety, patient safety, as well as employee safety. We have a lot of items, a lot of projects in our facility we can consolidate into that, but engage our staff into processes, workflows, getting their input as far as how we develop policies, procedures, and giving them opportunity to engage themselves in what we've got going and form a positive culture. Proactive risk assessments. That will continue on our agenda as we have 2 different units, clinical dependency detox, now inpatient. Those will be our focus coming into 2018. Next page on 13. There's our scores for patient satisfaction. Needs and challenges, page 14. Direct care positions have always is still a priority for us. It does directly impact our delivering care. We'll continue focusing on that. We have proposed nurse tech shift change to 12 hours, just as our nursing has moved to 12 hours back in November. It's been working great since the nurse tech portion of things. They're all on board. They welcome the 12-hour shift. That will help us as well to treat place more help towards the different units IMRU. Key vacancy positions, we've opened up our support service manager maintenance position. We've already, like I said, filled our position, our key position support. At the bottom, still, and this is considered a challenge for us, as we still, like I mentioned previous, we still have 4 non-funded patients or other, those within the region and our national facilities. NMRC right here is 44%, while regional is 50%, national is 20%. So it does pose a challenge, but again, this is something we can also be proud of. We're providing that idea of health care. The success stories is really based on what we've been doing in terms of meeting our financial goals. developing those joint commission for revamping, re-enhancing, developing our commitment to our patient safety and quality program. Continuing patient reopening, been effective. Effective March 5th. Detox programs still continuously moving forward, making enhancements as we go. Went really well with surveys that went well with billing. Key staff, there's a lot of positive things going on right now. Especially our community outreach as well. I'm not sure if there's any questions that you might have in regards to any of the slides.
Is there any questions for Jose at the New Mexico Rehabilitation Center? Not seeing any, Jose. Thank you so much. I know you're very busy there with Joint Commission, so if you need to go, that would be fine. Thank you for joining us by phone.
Thank you, Gabby. Bye-bye.
Bye. Next, we have Joe Marshall from the Los Lunas Community Program.
Morning. So the services we provide at Los Lunas Community Program are all provided person-centered. We use the interdisciplinary team approach to promote independence. We offer living supports, customized community supports, community integrated employment, our dental clinic, and our immediate care facility for individuals with intellectual disability. In our living supports currently, our average census for the last quarter was 59, 1 in intensive medical living and 4 in crisis. Our customized community supports was 56, our community integrated employment 28, and we had 2 at our intermediate care facility. Our unduplicated total was 67 and our duplicated total was 148. We serve 34 Jackson Pass members and 570 in the dental clinic. Our projected overage, currently we're at 1,732,387. That's down from the 2.2 last quarter. The majority of our contract costs are in nursing services, and they're averaging about $30,000 a month. Our total costs of earned income as of December was the $685,989. Our billings are $567,569, and our uncompensated care is at $31,626, and our collection rate's at about 92.89%. Our overtime trends are going up. A lot of this is due to what we've been doing on the campus with our anticipated move to the campus. We've been conducting fire watch, and it's quite costly, so until we get the new fire panels installed, we'll probably see that our overtime will be high, and also due to our vacancy rates right now. Our planned projects are really centering around the move to the campus. We've got our plan to move into and upgrade cottages 3, 4, and boroughs, and we're also going to be including the maintenance building into that, at least from an IT standpoint. And then the priority 2 would be our second phase of that move into the other 2 cottages, 5 and 6. Our total FTE is 302. Our total filled is 259. Our facility vacancy rate's at 16.55%, and indirect care is at 14.24, which is higher than it's been. Our workers' compensation injuries this quarter were 2 out of work, 2 and 1 reassigned. We have 10 on continuous family medical leave, 11 are intermittent. Our services, we have requested a self-imposed moratorium this month due to the high vacancy rates in direct care and our agency nursing, and we did receive approval from DDSD on that self-imposed moratorium for 3 months. So we won't accept any admissions except for ICF, employment, and rehabilitation, and then any crisis admissions that come through. Our staff, we're actively recruiting nursing, our certified medication aides, and we're attending every job fair that we can that's free. We're posting positions on the SPO site, over to Indeed and Craigslist. We are a CMA training site. We've been struggling with actually starting that because of our agency nurses and the agency nurse changeover, and we're still working to try to have a rapid hire event. Our community connections and outreach, we're continuing with discovery. It's been really successful for us. We have incorporated it into the individual support plans, and we've expanded the use of discovery from just the employment and our informed choice into the meaningful day, and really incorporating positive outcomes for the people that we serve. And it was really positive feedback that we were given for discovery through the Jackson audit review. So our licensure and accreditation, we've this quarter had the three major reviews. We've had the health facility licensing and certification survey, December 27th through December 29th. And at the time of this review, we haven't received the 2567. We received it since then. It's due next week. We have very minor findings. For the GD waiver services, the quality management Bureau survey was October 27th through November 2nd, and we still have not received their report at this time. During the exit review, we were told that it would be very minor findings, and the individual quality review for the Jackson review that was completed on December 13th, and there were very minor findings. The trend we saw with those minor findings were with nursing due to there being agency nurses and us not having a DON. We are posting our D1 position, and we're working on that continuity of care and have some ideas for how we're going to address the continuity of care. Our other initiatives, we're still having town hall meetings, brown bag with leadership, team building, quality assurance. Our staff communication committee is rolled over into the voice of the customer committee, one-on-one with the administrator. We have our extra mile awards and employee appreciation awards, and we're working on our on-the-job training manuals. Any questions? Thank you.
I don't know if it's really necessary, but the lady that teaches the CNA course, she also provides CNA training.
Oh, great. Okay.
There's no questions for Jill. We'll move on to Turquoise Lodge and Shona Hartley. Good morning. So this first slide identifies the services that we continue to provide at Turquoise Lodge Hospital. We continue to provide medical detox, social rehabilitation, which is a 21-day rehab program. We have a contract with the county to, as a vendor for their MO2 clinic. And in last quarter, identified a new service, our intensive outpatient services. And in this quarter, we actually started an outpatient medication management clinic. So on Thursdays from 2 to 4, Dr. Mirren, our medical director, is actually continuing to see patients who are in our intensive outpatient program or have been discharged from our hospital or psychiatric services. Some service provision highlights this quarter is that we are trying to increase our IOP resources and census. We started our new service line, outpatient medication management clinic, and myself and my safety director and George Morgan participated in our DHI life safety survey, which was in December, which is a part of us being able to approve our joint commission application, which is required a CNN number from DHI in order to do so. And I'll talk a little bit more about that. Our data that we have this quarter, we actually have increased one of our medical detox beds. And in accommodation to starting our intensive outpatient program, we were doing a 5-day detox, but we've actually extended that to 7 days so that we can start capturing some of the folks that can actually come into our own system for outpatient services. So we increased one bed in our detox program. And significant data to talk about this quarter is that our social rehab numbers have gone down a little bit, and that's not unusual during this time frame because in our hospital during the holidays and so forth, sometimes people aren't interested in recovery or seeking substance abuse services. So this is not an unusual trend. This quarter, we provided services to one transgender patient, so we are tracking that data. Significant data to identify is that we have provided a 3% increase towards our Native American population this quarter, which is good. And pretty much the data remains the same. The breakdown of the individuals that we serve, we actually had a 6% increase in individuals who had a primary alcohol condition and a 5% decrease in individuals who present with a primary opiate dependency. We continue to provide services to the same age range. We're always providing the majority of our services to that kind of 20 to 40 population. But it is significant to note that our 51 to 60 population increased 4%, which is presents a much more complicated patient. Sometimes individuals in that age range have more medical conditions. We have to have our internal medicine doctor intervene a bit more. And so, we've been doing a pretty good job with that. This is new data for us for our intensive outpatient program. What I did is I broke it down by all the different services that you have to provide in order to admit someone into that program. So it's not just the groups, but every patient has to have a comprehensive assessment prior to admission, which identifies the diagnosis, which makes them appropriate for the service. They have to have a treatment plan before they go into our group. And then our MD meetings, our MDT meetings are basically the staffing of the patient throughout the program. Right now, we started our program about 4 months ago, and so we can only go to 15 with the matrix model that we've opted to use. And our average census is between 8 and 10, which is pretty good for 4 months of programming. And we've had about 3 people graduate this quarter. Our MO2 data is about the same. When I looked at last quarter, we served about 75 people less than we did last quarter, but again, people seeking substance abuse services during the holiday season tends to go down a little bit. Our financial updates, we pretty much stay about the same. We hit our mark every month. In our hospital, we do provide a lot of unbillable services. So our 21-day rehab is not a Medicaid reimbursed service, so that tends to increase our uncollectible and unbillable charity care. Because we aren't accredited at this point, we aren't able to bill for Medicare services. And a lot of the folks that come into our hospital do not have health insurance, and when they come into our hospital, we really can't make arrangements for them to get that prior to being admitted due to the patient presenting in the sense that they do. One thing to highlight this quarter is that we've actually had a 7% increase in self-pay collections. We actually have a PDSA through our quality improvement department, myself, my finance director, and a couple of other folks. And what we're doing is that we're just really increasing the communication with the patient. So we are tending to get increased self-collections, which is good. Not much to report on my contract costs other than the good news is my contract nursing is down about 10,000. And so that was due to one nurse hire this last quarter. So we hope to see that trend continue. The individuals that we've hired in our hospital this quarter is one nurse tech, one nurse supervisor, which is pretty significant. I'm trying to have a nurse supervisor on every shift. We hired an HIM director, and one big hire for me is the director of clinical services. I've been kind of managing that department kind of on and off for the last 4 years that I've been in this position. So we hired Brenda Frank, who is actually my quality director. And she's now going to be overseeing all the clinical folks in addition to our new outpatient services. And so we're really excited about that. This last quarter, we really focused on improving staff skill sets. And so I had 5 other staff trained in our matrix model, which gives us more resources to facilitate those groups. I started implementing a bi-monthly RN supervisor meeting to support the nursing department. Myself and my HR director put together a PowerPoint presentation for our nursing staff, and so we did 98% of a professionalism training, really focusing on, being ready to work, customer service, being very patient-centered. And myself and my safety director and George Morgan had the value of participating in our life safety survey with DHI. That was in December, and there were some life safety issues that were identified. And so the next step, because we lease our building, is that we are going to sit down with our landlord and identify what those deficiencies are and move towards next steps to address. So this holiday season, we're really focused always at Turquoise Lodge on really giving to the patients, and one of a recovery skill that we wanted to focus on this year is actually giving to others. And so we turned our whole entire hospital into Whoville, which was like super, super fun. That was kind of an ongoing process for about 30 days prior to Christmas. We had our rehab patients actually sing Christmas carols, so we had our own tree lighting. And on that day, we had our rehab patients actually sing Snoop Doggy Dog Christmas carols to our medical detox patients and our staff, which was really fun. And we also made sugar cookies, and we had a celebration with that. We also, this year, we always do the recovery luminarias, and we normally actually decorate our own campus, and so the county who we lease from gets to benefit from that. But what we did this year is we went to the Endorphin Power Center. We have a contract with them, and we actually created those recovery luminarias for them, and then we had a lighting on site with them, and so it was really, really nice. In addition to this process, we actually had a fundraiser, and some of you in this room participated. We raised enough money for all the patients who were safe to go to the River of Lights this year, and that was really, really fun. When we got back, we really processed with the patients about kind of creating different memories, and 99% of the folks that went with us had never been to that, including myself, so it was really cool. And so we had a really, really good time. The marketing and outreach efforts, we really stepped it up, I think, this quarter, and made some pretty significant relationships with probably 3 of these folks who are identified on this document. I am trying to actively work with UNM to reestablish what's called a PIC line contract. So we do have patients who go into UNM hospital, and then they require a PIC line, and they have to be in a hospital setting for about 6 weeks. And so we're in the process of talking with them about how we can reestablish that relationship and perhaps start taking some of those patients that are not acute to stay in the hospital, but too acute to go home. Another significant relationship that we made this quarter was with Sage Neuroscience. And so they're an outpatient facility that provides the same services that we do, but we're actually, based on that interface with them, starting to fast track some of their patients who are in their outpatient clinic but need to have medical detox. We are trying to collaborate with Jennifer Weiss at Serenity Mesa, so that if we have patients in our hospital 18 to 21, we might keep them a little bit longer, actually get them associated with our outpatient clinic, because one of the things that she's been struggling with a little bit is that people get admitted into her facility, but then they don't have psychiatric services. And so we're trying to take care of that population, that 18 to 21 age range, in a better way here at our hospital. And that is a beautiful picture of our paper mache project that we did in November. So I don't know if anybody has any questions.
Any questions for Shauna? Next to ALTSD Treatment Center from Allison.
Sequoia is a voluntary residential treatment center serving adolescent males between the ages of 13 and 17 who have a history of violence, mental disorder, and is amenable to treatment. Our average census is about 27. Our goal is always 30. However, we've been able to maintain between 27. Sequoia is scheduled for their licensing survey in February, which they will be assessing our environment, our administration of medication, medical records policies, life safety, fire safety, staff to resident ratios, human resources, and training records. We're also due for our environment department, our kitchen, to be inspected now, anytime now. We've also submitted our Title I application, and our 80-day count was submitted to the Public Education Department. Our projects. We completed our first phase of the courtyard renovation, which was the drainage system. This project was not accepted, unfortunately, and resulted in the project being redone. This project seemed to be a little bit challenging for Sequoia because it surfaced a lot of rocks because we sit on a riverbank, and because of our population, our residents use the rocks to throw at our windows when they get aggressive. So that's been really challenging to have to pick them up. They're scheduled to go in and redo the project, or the last phase of it, coming up this month. The second phase of that project is the landscaping, so we're really looking forward to that, to kind of put the rocks to bed. The roofing project was completed also in our gym area of the facility. Our financials, we continue maintaining our census at 27. At the beginning of our fiscal year, our goal was 30. We've had to adjust that to 27. We've adjusted it to 27, but always keeping our goal at 30. Contracts costs include the high end is for nursing, dietary, dental, our nutritionists are the lower end of our contracts, and Central Region Education Co-op. The higher end is nursing. Sequoia maintains their billing or their collection rate at 94%. We're doing electronic billing, which that's helped in our collection rate. We've also began billing for costs not covered by the insurance. Oftentimes, insurances are indicating that the residents meet a lower level of care, so they'll stop payment 3 months into their stay at Sequoia. So we've started billing guardians and families and making financial arrangements for the rest of their stay, because we believe that they need to stay in transition in another month or two. So we bill for those uncovered costs by the insurance. Our cost containment, even though our vacancies are kind of high, we've also have decreased our overtime, and the way we're doing that is by daily assessing our schedules and making sure we're maintaining ratios and having the number of residents moved. We have 4 lodges, so we move our residents so that way we can adjust our staffing accordingly. So we've decreased our overtime by 19%, so we're proud of that in comparison to last year at this time. We're also exploring billing our parents or guardians for property damages done by the residents, and these are damages that are done to our life safety, like our fire alarms, our doors, those type of stuff, those significant damages. And we're working with OGC and on that project. Our human resources, we have currently 27 vacancies, which are all direct care positions, which is nursing and psych techs, our mental health technicians. We've lost currently 2 of our clinicians who have joined the mental health task force with law enforcement, which supports the mayor's initiatives. So they're really excited to be riding along with law enforcement. So they've left our facility, but really proud of supporting the new initiatives that the new mayor has. We also lost our principal, but we're fortunate to have a good pool of applicants, and we've selected a new principal, who is Angelo Archuleta, coming from the northern area of New Mexico, and he started in December. We continue to educate staff and our residents and visitors on the flu, getting protected and promoting good health are our core principles. This reporting period, we encourage our visitors to mask before entering, and we have a pretty good reception with that initiative. Sequoia has entered 100% of their training records into the Smart Sheet, so that was an accomplishment. Our performance measures, we continue to collect data for our restraints, and over the last 2 to 3 years, we've been able to lower our restraints almost to none, and we're really proud of that. Sequoia does not use mechanical restraints. We use holds, and from looking at the data, our restraints are very minimal. Very proud of the staff at Sequoia. They've really strengthened their toolbox on their de-escalation techniques. We're sending 2 of our trainers back to get recertified, and they're going to be taking the enhanced course of the crisis prevention intervention model that we use, and that'll be done in July. We also have been monthly doing some training targeting specific departments, so we do breakout sessions every month, and each department targets the area of needs that they've identified for that month. Lastly, I want to thank the DOH staff out of the Reynolds buildings for sponsoring the Sequoia residents. For Christmas, they were all able to receive hygiene items, socks and underwear, snacks, and a hoodie. Each resident received that. So I want to thank the DOH staff for sponsoring the residents. Also, Coats for Kids have recently provided a quote for each one of our residents, and we received them just last night. So, any questions?
Any questions for Carmel? Then we'll move on to next behavioral health. Again, Susie Archuleta will be giving the presentation for Francis Street.
NMDOH is the mental health safety net. Adult psychiatric division is licensed for 121 beds. Adult and psychiatric hospitalizations, we can only state psychiatric hospital in New Mexico, legal and clinical criteria for admission. The forensic division, licensed for 160 beds. Treatment to competency, 40 to 50% of patients have been found to be non-competent and non-restorable. NMDOH provides specialty health care services, the care program licensed for 20 beds, adolescent treatment program, long-term care division licensed for 176 beds. The vast majority have a history of psychiatric illness such as dementia, nursing home care. Community-based services division has approximately 1,100 clients, are served in the Tri-County area of San Miguel, Mora, and Guadalupe counties. Assisted living facilities with 29 licensed beds, inpatient and community-based outpatient stores. The adult psychiatric division has 6 units and has 96 operational beds. Forensic has 4 units and 84 operational beds. Care has 1 unit with 12 operational beds. Long-term care has 4 units with 163 operational beds, and the community-based service has 4 outpatient units. Our average daily census by division. Adult psychiatric division in October had 70, our census was 70, in November was 76, December 73, and the average census was 73. For forensic in October 46, November 42, December 43, average census 44. Care unit was 9 in October, 9 in November, 10 in December, average census was 9. Long-term care, October 151, November 150, December 148, our average census was 150. And our total for the average for the quarter was 276. Outpatient census information. Plans for programs, psychiatric was 994. Psychotherapy was 152. The CCSS was 11. Psychosocial rehab was 38. OPRS was 30. Total number of census clients receiving services was 1,077. This includes Las Vegas, Pecos, Sonora, and San Francisco. Accredited by the Joint Commission. The triennial TJC survey was conducted from 8/15/17 to 8/18/17. NMDOH is pending the approval of our corrective action plan for submitting additional information on the progress of the Licensure project regarding all adult psychiatric division improvements. The estimated date of completion of the Licensure project is April 15th, 2018. The estimated cost of the project is approximately $1.2 million. Licensing long-term care annual survey occurred from 7/24/17 to 7/31/17. The corrective action plan was accepted on 8/25/17. A complaint survey was conducted on the adult psychiatric division on December 6, 2016, due to a complaint filed by a former patient. There were no, it should be 2017, not 2016. Due to complaint filed by a former patient. There were no findings as a result of this survey. Financial for Y18, NMDOH does not segregate on operating budget for each service line that we provide. Revenues, general fund, $29,342,100. Total project other revenues is $27,500,900. Total project operation budget is $56,843,000. Uncompensated services provided. Projected uncompensated care for the quarter was $5,284,687. Uncompensated care is due to the following: to indigent residents at long-term care, no funding for forensic residents. Average payment for APD patients who have insurance is only for the 3 to 5 days after admission. No payment for the APD patients that were admitted on a 30-day court commitment. Difficulty finding safe discharge placement for APD for some APD patients. Contract costs. Projected FY18 amount is $3,798,200. There's the pharmacy for the anticoagulation program, religion and the nursing services and medical services, religion and cost report service, transcription, fingerprinting, drug, alcohol, pharmaceutical waste disposal, confidential document shredding, electronic claims, eligibility services and food services, and hardware, software maintenance, and support services.
Hi, this is Erin on the phone, and suddenly I'm not able to hear.
Okay, so look into that.
Okay, sure. You just got fuzzy.
Other financial information. Second quarter collection rate was 84%. The challenges our facility faces in collection of payments is we only have 2 follow-up clerks, entry-level positions that work on denied claims, and one of these positions has been vacant for 5.5 months. A follow-up clerk was hired and is scheduled to start on 1/27/18. Cost containment efforts. NMDOH has implemented the following initiatives. Continue the practice of requiring receipt of weekly invoices for major account. Continue to evaluate level 101s on a daily basis. UR committees reviewing the LOS on all patients at APD and assisting with the discharge plan. Continuous reevaluating staffing levels. We recently decreased staffing levels again in an effort to decrease mandatory overtime. ICIP projects, funded projects, college renovations, anticipated completion date is March 2018. Roof replacements, majority completed. Campus surveillance systems, almost complete. Meadows Phase 3 amendment in process. APD HVAC replacement on hold. Asbestos abatement, Zia building, which is the care. The ICIP request. Literature Points, anticipated completion date is mid-April. Unfunded projects request, fencing of APD and surrounding buildings to prevent buildings. Human resources, direct care vacancy rate is at 26%. The nursing department currently has a 34% vacancy rate for site techs. This represents 102 FTE positions. The vacancy rate for nurses is 25%. This represents 26 vacant FTE positions. And employee hires by month, October we had 7, November we had 14, December we had 7, so total 26. There were 14 techs hired during the rapid hire event in October 16, 2017. A rapid hire recruitment event is scheduled for January 16, 2018, and will be held quarterly. Recruitment and retention PI team has been meeting bi-weekly. The initial work is on recruiting and retaining site techs. The following progress has been made. Advertising in the local newspaper every Sunday until June. LinkedIn and Facebook and Craigslist. Quarterly rapid hire recruitment events. Ongoing interview process. Retention efforts. The R&R team is working on the following recruitment efforts. Each nursing division is standardizing a more thorough initial orientation checklist. Nurse managers will meet with new hires at 30 days, 60 days, and 90 days. Identify tech positions for job sharing. Work on PRN tech positions. Identify the position and hire PRN nurses. Facility performance measures. Number of falls with injury per 1,000 long-term care resident days. Our target is 3, and we're at 0.22. Percentage of operational beds occupied. Our target is 90%, and we're at 80%. Vacancy rate in direct care positions. Target is 10%, we're at 26%. Percentage of eligible third-party revenue collected. Our target is 92%, and we're at 84%. What do our patients say about us? December 2017, APD, FTU, and care. There's 90% overall satisfaction with care and service, 95% overall satisfaction with feeling safe, 95% overall satisfaction with food that was served, 97% overall satisfaction with the facility being clean and comfortable, 95% overall satisfaction with patients being respected, 95% overall satisfaction with activities for offered. Community connections. On October 18th, 2017, NMDOH's PR coordinator participated in the recruitment fair at New Mexico Highlands University. On October 20th, community-based services participated in a health fair and recruitment event in Santa Rosa. On October 31st, community-based services participated in Booth Fest, a community program for children. CBS had a booth with pamphlets about mental health. On November 2nd, NMDOH's care coordinator and Bill Shelter, CNO, attended a career fair at New Mexico Highlands University. On November 9th, community-based services participated in the health fair and recruitment event in Boston. Training initiatives. October 8th through October 12th, 2017, the AHIMA annual conference and enrollment. HIT director attended. 1013, treatment planning APD treatment planners. 1021 to 2022, NAMSS educational conference, Michelle Fields DOH credentialing coordinator. On 10/22 to 10/27, health sector emergency preparedness training, Brenda Ortiz. 10/23, treatment planning, care treatment planners. 10/26, documenting and health record, deputy clinic staff. On 11/2, office ergonomic assessor training, Alfonso Garcia trainer. 11/2, emergency preparedness, Susan Bertha and Linda Trujillo. On 11/2 to 11/3, fundamental for infection prevention of for long-term care facilities, Melinda Carson Bailey, our infection prevention control officer. On 11/20, Melissa Walker met with management team and reviewed the NMDOH requirements. Holiday celebrations. The Patient Foundation sponsored a raffle to raise funds for patients. The raffle drawing was held on December 22nd. Pictures are H.C. Hawkins, Safety Hospital Administrator, Mabel Argoyo Vasquez, our Executive Nurse Administrator, and Francis Tweed, our Administrator. The $3,400 was donated by the Foundation for Christmas. Each patient, resident, client received $10 for Christmas from the Patient Foundation. Holiday celebrations, long-term care residents were given gifts donated by an individual from Los Alamos. It is pictured in the photo. Long-term care sponsored a holiday dance with a live band. On Christmas Day, the residents had eggnog and cookies while they opened their presents. Presents were brought for each resident with the money that was donated by the Patient Foundation. Holiday celebrations, APD Rehab Services sponsored a dance with a brunch-style meal. Numerous people donated gifts with our Care Kit residents, including employees from DOH and Santa Fe. Each resident received gift cards, stockings that had a pizza party. CBS took some clients to lunch. SU played bingo and watched a movie. NMDOH celebrates our 125th anniversary. In 1989, New Mexico Territorial Legislature passed a statute creating the state hospital. The hospital opened to the public in 1893, housed 41 patients, and was then called the New Mexico Insane Asylum. In 1935, there were 716 patients, and by 1953, the number had risen to 1,100 individuals. When the Mental Health Code was enacted in 1977, there were 250 patients housed at the hospital.
Does anyone have any questions? So we will be looking at some celebrations with the anniversary of the state hospital, probably in the spring, early summer. Does anyone have any questions for Susie for NMDOH? Seeing none. Thank you everyone for your presentations this morning, and if I can get a motion to approve the facility administrator reports. And a second? A second. All in favor?
Aye.
Anyone opposed, or anyone have any questions or concerns? Seeing none, the facility administrator reports are approved. Next, we'll move on to the preliminary six financial report. So before you start, like the Dr. Collins, are you on the phone at this point?
Yeah.
Okay, thank you, just making sure. We'll take you next for the policies and credentialing after Roy's financial report.
Okay, fine.
Morning. My financial report is for the period ending December 31st, 2017. Program Area 6 is currently projecting a year-end deficit of approximately $3 million. To give you a rundown of the 16 actual, our deficit was 3.1 million. For 17 actual, we had a surplus of 3.27 million. And in 18, again, we have a projected deficit of 3 million. Our operating budget in general fund, we have $54 million to operate facilities management. Barrett Medical Center lease is approximately $4.05 million. Interagency transfers is $1.1 million. Federal revenue is $3.99, and other state funds is $60.8 million. The total operating budget for program area 6 is $124.07 million. Not going to go over in detail every single program area, but this basically breaks down each program's OPBUD. This is not necessarily what you're projecting, but this is what we started the year off with. And finally, the Facility Management Division's performance measures as of September of 2017. You may have some new updated numbers here soon, but I'll just go over the numbers that ended September of 2017. The vacancy rate for direct care positions, our target is 10%. We're actually at about 25%. Percent of eligible third-party revenue collected in all agency facilities, our target is 93%. We're at 85% back in September. Percentage of long-term care residents experiencing one or more falls with a major injury, our target is 30%, and we're at 2.2. And our percentage of operational beds occupied, our target is 90%, and our actual is 83%. With that, I'll stand for questions.
Question for Roy on the financial report. Seeing none, I'll ask for a motion to approve the financial report. Noel moves, is there a second? Second. And Joe second. Is there, all those in favor of approval?
Aye.
And anyone opposed or any questions? Then seeing none, the financial report is approved. We'll move on to approval of policies. Dr. Daniel Collins is on the phone.
This is me, I'm here. Are there any policies that need to be reviewed or approved today?
They're included in the packet. I believe it's for NMRC and NMDOH.
Has everyone had,
We have a motion to,
has everyone had an opportunity to review those? They were attached to your packet. Does anyone have any questions or concerns about the policies from NMDOH or NMRC? Seeing none, go ahead, Dr. Collins.
we have a motion to approve policies as written.
I make a motion to approve the policies as written. Second motion.
All
You have
those
a
in
second?
favor? We have a second. Everyone in favor, say aye.
Aye.
Anyone opposed? Policies as submitted to the governing board are approved. Go ahead, Dr. Collins, on the credentialing.
Alright, so moving on to credentialing, what I'll do is read through the provider names by each facility and the type of privileges, reappointment or initial privileges, and at the end, I think we'll have a motion for all facilities together instead of doing each one. How does that sound?
That sounds perfect, thank you.
Okay, Fort Baird, we have Laura Davenport Reed for reappointment. We have Robert Garrett for reappointment. We have Adam Gulp for initial. Felicia Meyerowitz for reappointment. Johnny Reed for reappointment. James Ski for reappointment. Lori Yablik for reappointment. LLP non-NMDHI, we have Natalie Armillo for reappointment. Daniel Baca for reappointment, Cheryl Burlett reappointment, Daniel Collins reappointment, Annette Noel for initial, George Weir reappointment, Erica Johnson Jimenez for initial, Gwendolyn Minton for reappointment, Catalina Perez Lacey for initial, Kimberly Sena for initial, Matthias Strickard's reappointment, that's Fort Baird, that's NMDHI. Moving on to NMRC, we have Marilyn Hines for initial, Stephen Hancock for temporary. Moving on to Public Health, Kristen Earthkovich for reappointment, Stephanie Welk for temporary and initial. Moving on to Sequoia Holly Bauer for reappointments. Moving on to Turquoise Lodge, Diana Darabont for reappointment, Zachary Elder for initial, Shannon Foskey for initial, Ludmila Grenikin for initial. We have a motion for all, for each facility, all providers to approve.
I so move.
Do you have a second?
Do you have a second?
I'll second.
Okay, that's it.
Thank you, Dr. Collins, I appreciate it. Moving on to our next,
I'm have to leave. I have some other things I have to take care of.
of course, thank you.
Okay, bye-bye.
Moving on to our next agenda item, it's our annual review of the governing board bylaws. I know we just reviewed them recently, but according to our bylaws, we have to make sure that we're looking at them at least annually. And then at transitions of secretaries and that kind of thing. So if anyone has anything you'd like us to amend for the bylaws, we can make a mention of that now, and then we can take a vote on it next time. But after reviewing the bylaws, does anyone notice anything for our annual review that would need to be amended?
I have a point on 7.04, Dr. Medical Staff.
What page is it?
Page 5 of 8. The medical staff bylaw approval refers to the governance documents of all 7 facilities. No longer have 7 facilities.
I have something on the same page at the top, so it's page 5I. It says pursuant to these bylaws at Article 8, the agenda will include the review of bylaws in the case of a new secretary or acting secretary. It should be review of the bylaws annually and in the case of, if you look at that section, it actually asks, so it's annually and in the case of your acting secretary. Is there anything else that would need to be amended that anyone else noticed in the bylaws? Not seeing anything. They have a motion to, because they're just technical amendments, can I get a motion to make those 2 adjustments to the bylaws on page 5?
So moved.
A second, please. Second. And all those in favor of making those clerical amendments to the bylaws?
Aye.
Aye. Anyone opposed? Okay, motion passes. The next thing on the agenda is to do our self-assessment, which is also required annually on page 5 of the bylaws. And basically, the self-assessment includes just making sure we've had members in attendance and that issues have been resolved, that all the meetings have been held, and that the board is otherwise performing its duties. We have definitely had all the meetings that we're intended to have, and all the minutes have been captured and they remain on record at the Office of the Secretary for Department of Health. We haven't had any attendance issues with anyone. We did have a couple of people attend by phone today, or Jose, but he was excused because the Joint Commission is present at his facility. So if anyone has any concerns or anything else about the performance of the governing board, please bring that to our attention now. I'm not seeing anything. We'll move forward. If I could just get an approval that we have completed our self-assessment for the governing board, a motion to approve our self-assessment. Anyone opposed? Anyone, all those in favor?
Aye.
So announcements, our next meeting will be Thursday, April 19th. We will consider a location at a different date. Unless anyone's dying to volunteer, to have it at your facility, speak now. Okay, we will address that. I did want to mention that I want you to start thinking about transition planning for the next administration. We will be talking about it probably more in October than in April, but I want you to start thinking about the kinds of things that you want to present to the next administration. Of course, there'll be an election in November, so we would know in November who the new governor of New Mexico will be, and they're, of course, in charge of all executive agencies. So there'll be a lot of transitions of all the exempt positions, including mine. So we want to be able to hand off the facilities to the next administration in a way that we can be proud of, to show them the things that you've accomplished, but also really to make sure they're aware of the things that you have coming up, whether it's the capital projects, you know what I mean, the kinds of challenges that you've been having, and just really, you know, the handoff of the baton, so they appreciate things that you like the way they're working. Maybe we can make a note of that, things that you want to change. I want people to be really honest with the process, so we can, like I said, we can do an honest and a meaningful handoff. Okay, start thinking about those things, and we'll probably have it more as an agenda item in terms of our internal meetings, but we could give reports to the governing board about that. I know the governing board itself has gone through transitions, you know, different administrations have come in, so it will be important for you all to articulate what's working about the governing board and what isn't, and if we can make any of those changes in the bylaws or that kind of thing that you think would be important for the administration, the next administration to know about, it would be, you know, let's talk about that, like I said, have an honest dialogue so we can leave it in the best position possible.
At what point next January will the transition take place, before or after this?
Oh, the transition will take place, usually the transition teams come in right after the election. I would think we'd have more of a transition meeting with the next administration in December. I have to have a special meeting, you know what I mean, or that kind of thing, because by the next January meeting, you will have a new administration. So anyone else needs to make any comments? I don't know if there's anyone from the public on the phone or anything. Seeing none and hearing none, we'll move to a closed executive session. During the closed session, we will not take a vote on any items that need to be shared in the public forum.